Thank you for joining us. Finally having some good weather. How's it up in Portland right now, Allison?
It's beautiful. Yeah, it's really nice. How about where you are? Where are you, in Bend? Or?
We're in Bend, yeah, Central Oregon, and we've had the weirdest weather.
Oh dear.
We
What's it doing today?
Well, now it's gorgeous, and I'm hopeful for a good weekend.
Good. Yeah.
You
guys had a lot of snow last weekend.
Yeah. Makes me worried for all of our unhoused folks in our community.
Yes.
Or older folks.
Yeah, it's risky out there.
It is. Well, I'd like to give it until 2 after the hour.
Sure, so no problem.
1 more minute.
That's just fine with me.
Okay.
Check something real quick here.
Okay, let's go ahead and just jump in. So welcome everyone to this month's presentation from the Partners in Care Community Education Series. I'm your host, Joelle Blanchard, and today we have a special guest who is joining us from the Layton Center at OHSU. Dr. Lindauer is a nationally certified gerontological nurse practitioner and scientist. As an associate professor at OHSU's Layton Aging and Alzheimer's Disease Research Center, she cares for persons with dementia and their caregivers. With over 20 years experience in aging care, Dr. Lindauer conducts research on dementia, caregiving, and telehealth. As a leader of outreach, recruitment, and enrollment at the Layton Center, Dr. Lindauer oversees community-based activities and study recruitment. She is a preceptor and mentor for students in health-related studies. So before we get started, just a few housekeeping items. You are all muted and do not have video capability. And if you have a comment or question, please use the Q&A feature. I will be checking the comments and questions throughout the program, but we will hold exchanges until the end of the presentation. So with that, thank you, Allison. Go ahead and get started.
Great, thank you. Thank you, Joelle, for inviting me. This is really a nice opportunity for me. It's important to me that our center serves all of Oregon, so I'm especially delighted to be meeting with you today. So again, my name is Allison, and let's just jump in. Wait. Excuse me, just a minute. Okay, so again, my name is Allison. I'm a nurse practitioner at OHSU, and I also am a scientist. I have my PhD in nursing, and I conduct research there. Joelle, you can see my screen, yes?
Yes, we can.
Terrific, thank you. This is my email, so if you have questions, you're welcome to email me if I didn't answer them today. Today, I want to talk about caregiving and dementia. This is really the heart of what I do. So it's really a topic that I care deeply about. So a little bit more about us. The Layton Center is one of actually 33 NIH-funded centers around the United States where we conduct research about everything memory. So we do studies that look at what happens before people have memory trouble. We look at, we work with people with mild cognitive impairment. We work with people with more advanced dementia. We also have different approaches to our research. So some of our research is technology-based, where we have special devices in homes to assess how people are doing. My team and I do caregiver-based research, trying to find best ways to support families. We also have a neuroimaging and pathology group that helps us with our work. And then, of course, we do provide evaluation and treatment for people who have memory trouble and support their family members. Today, I'll be talking a little bit about what is dementia, but I also will be talking about my research. I'll show you this slide again later, but this is what I do. I use telehealth to reach out to caregivers, work with them on challenging behaviors they're dealing with to see if what we do is helpful. And this is also funded by the NIH. But I'll show you this again so you don't have to memorize it. So let's talk about dementia. First, many of you, I'm sure this is repeat and I apologize, but I like to have kind of everybody on the same page. So as you well know, dementia is an umbrella term, right? It's the term we use, the general term, and then there are different types of dementia. So there's Alzheimer's, vascular dementia, Lewy body, FTD. There's lots of different types of dementia, but all the dementias are neurodegenerative, meaning that they progressively kill brain cells that affect our memory, our mood, our thinking, and our function, and our behavior. When we see somebody in the clinic who is having memory trouble, we apply these very specific criteria to see if we can actually give them a diagnosis of dementia. Once we've established that they do have a dementia, we work within our knowledge base to understand what type it is. So first we want to know, do they have memory trouble or cognitive trouble really that interferes with their ability to function at work or usual activities? Is it a decline from previous levels of functioning? And make sure that the person doesn't have a major psychiatric disorder or delirium. So we got those criteria, and then we look at the impairment domains. So along with having cognitive impairment, which interferes with function, they also have to have problems with acquiring and remembering new information, reasoning and handling of complex tasks, visual, spatial impairment, impaired language, personality, behavior, or comportment trouble. So if they have two of those, along with the cognitive impairment, we give them the diagnosis of dementia, and from there we try to figure out what type of dementia they have. And we look at memory, we look at language, we look at function, we look at behavior. And it's important to know what type of dementia a person has, because it doesn't really affect a lot of the treatments. It does affect some of them, but importantly, it helps us prepare the families for what to expect with disease progression. And I'm sure as hospice professionals, you really get that. So let's start with the most common. What is Alzheimer's disease? Well, many of you know that it's a type of disease in which there's a buildup of sticky proteins called amyloid and tau tangles, and these cause the cells to die. Alzheimer's disease is a slowly progressive disorder, and so sometimes it's even hard to appreciate the changes. I like to think of it as a ball kind of rolling slowly down a hill. It's kind of slow but progressive, so it's hard to notice. And these are the families where, let's say the kids, the adult kids in their 30s come home at Thanksgiving to visit their parents, and they notice that, oh my goodness, mom really can't really manage the oven anymore. And perhaps her spouse didn't appreciate that because the changes are so subtle. So having somebody new and fresh come in and see the changes is often when we hear from families. Vascular dementia occurs because of strokes. So the brain cells die because there's a lack of circulation to parts of the brain that helps us think and remember. And obviously, people with higher risk for stroke, such as high blood pressure, poorly controlled diabetes, or cholesterol, they have a higher risk for vascular dementia. And vascular dementia has this progression where a person will be doing fairly well for long periods of time, and then they'll get bad quickly, and then they'll go along and they'll get bad quickly. So we call this a stepwise progression. So if Alzheimer's disease is a ball gently rolling down a hill, vascular is a step by step by step. Lewy body dementia is a different type of dementia that causes fairly difficult symptoms such as hallucinations, sleep issues, and what we call fluctuations. So a person with Lewy body will have periods where they're more confused, just a little bit families tell me kind of out of it, and then they'll be really clear and on top of things. And it's very confusing for these families. So they can be like very clear in the morning, but the afternoons they don't do well at all. Or they can be clear for a couple of days and then they just get really foggy for a couple of days. Every person's a little bit different, so it takes the families a while to figure out what's going on. And because it's kind of, it's hard to know what's going on. It's kind of like a bouncing ball. Like, when is it going to be good? When is it going to be bad? And families often will figure out the pattern fairly quickly. But this is a good example of where it's helpful to have a diagnosis so we can really tell people, okay, yes, it's normal for him to be kind of out of it at 2 o'clock and then kind of back at it at 6. People with Lewy body also have hallucinations. They see little people, little animals. The hallucinations are typically not distressing. They're just kind of curious. And then, of course, these people also have sleep problems, waking up in the middle of the night and thrashing about, that kind of thing. And then, sorry, I don't have a title on this. I want to talk for a minute about frontotemporal degeneration. Frontotemporal degenerative disorders include things like behavioral variant FTD or primary progressive aphasia. These are disease types that affect the front and the sides of the brain, so that the first behaviors are, the first symptoms are really wacky behaviors. So many of you probably heard recently about Bruce Willis having FTD. That's a really good example of the disease process. Some of my patients with FTD do have strange behaviors. For example, I had a patient that would mow the lawn for a whole day. I had other patients who would eat strange things. And I won't go into that. I'll just let you think about that. I had another patient that would want to walk all day, and another patient that wanted to watch the same episode of Gilligan's Island all day. Really kind of odd behavior that is a change from how they were. I bring up FTD because it affects younger people typically. It does affect older adults as well, but it often affects people in their 50s and 60s. It's very hard to get a diagnosis because it often looks like a psychiatric disorder. And so I work with the Association for Frontotemporal Dementia just to try to get the word out. If somebody has some really odd new behaviors, make sure FTD is something to think about. These are families that the dementia hits them in the prime of life. Not actually, that came out wrong. We all live in the prime of life, right? It hits them when they're most productive at work. They often have teenage kids, and these families need lots of support. And I just put a puzzle instead of a hill or stairs because it is a puzzling diagnosis and often very difficult to deal with. And so, probably like you, I make sure that my patients connect with the type of organization that best fits their needs. So again, this is another reason why we like to try to identify what the diagnosis is. So for example, if I refer somebody with frontotemporal dementia to the Alzheimer's Association, sometimes the needs just don't fit. But if I can get them to the AFTD, not only are they with people who are walking down the same path, there are lots of resources. For example, the AFTD provides a $500 grant every year to these families. Let's see, okay. And just another word about diagnosis. Our team can often whittle down and figure out what the diagnosis is, but sometimes we're wrong. And sometimes it's just really hard to figure out what's going on because a lot of people have mixed dementia. For example, they'll have Lewy body and Alzheimer's, or they'll have Alzheimer's and vascular. So we just do our best to support them. The other question I get, and I have a feeling many of you know this, but are there treatments for dementia? Not really. We don't have a cure. We have some new drugs I'll talk about in just a minute, but our standby drugs are the acetylcholinesterase inhibitors. These are medications like Aricept or Exelon, also known as donepezil and rivastigmine. These medications help slow disease progression. They don't make memory better. They just slow things down. So for many people, it's kind of a medication of faith. You know, we're making it so the person with dementia can stay independent longer. We do see improvements with these medications for people with Lewy body dementia. So those people should be taking these medications because it does diminish the hallucinations and it can help with those fluctuations. So those people we really want to make sure we diagnose. Memantine is another type of drug that helps slow progression, also known as Namenda. We often start this medication later on in the disease process. Both these drugs together not only help preserve some memory, they can also be really helpful in helping with behavioral symptoms like anxiety. Of course, for all of us, whether we have dementia or not, it's important to control blood pressure, cholesterol, and diabetes. That helps protect us from the vascular dementia. Many of you have heard about lecanemab, the other one, aducanumab. Those are two medications that have come out in the last 6 months. These are intravenous medications that are designed to treat people in the early stages of Alzheimer's disease. So they have to have mild cognitive impairment or very early mild Alzheimer's. It's not approved for people in the moderate to late stages. And it's an infusion that they take every 2 weeks. It is designed to, again, preserve a person's memory and function. Aducanumab, the one that came out in the fall, has been shown to preserve memory and function for about 4 months more than if the person didn't take it. It is an intravenous medication, and you do have to have MRI scans, and it does have some very serious side effects. So right now, we don't provide it at OHSU. We may in the future, but just wanted to let you know what's going on because I'm sure you've heard about it in the news. So let's talk for a minute about the caregivers. The reason I really love my work is because it's family-centered work. All of you know that dementia doesn't just affect the person that has the disease process, it affects the whole family. So I'm very concerned about everybody else. Let's talk about everybody else. In Oregon, we have about 70,000 people with dementia. There are at least 160,000 unpaid caregivers in Oregon. In 2020, we know they provided almost 300 million hours of care in 1 year, and that care was valued at $5.3 billion. That's billion with a B. I've given this talk before, and people have tried to correct me and say, oh, no, it's million. It's billion. The care that caregivers provide, and I bet some of you are out there, is both, I know it's hard, but it's such a gift to the state. Because if the state had to pay us to provide this care, we would go bankrupt, I think. Just some more statistics. Most people who have dementia receive only unpaid care from family. And most people who provide this care are women. And most people with Alzheimer's are women. So it's really a women's disease in many ways. Many report emotional stress. These statistics are from the National Alliance for Caregiving. I have a hunch they're pretty underrepresented, don't you think? With only 36% reporting high emotional stress, I bet it's higher than that. Many caregivers have trouble caring for their own health, and about 30% of those who live with their family member report feeling alone or lonely. I know many of you know Robin Tarter. She's a nurse and a PhD candidate that I work with, and she really highlighted for me how vulnerable our caregivers are because they weren't always well treated by the person that they now care for. What we do know from the literature is about 20% experience some kind of childhood mistreatment by the person for whom they are now caring. And I have a hunch that number is a lot higher. So when we do our work, we really avoid the word loved one. Not everybody loves the person that they care for. I'm just going to give you the cold, hard truth. When I talk about caregivers, when I reference them, I say, tell me about how your husband's doing. How's your mother today? What's going on with your family member? I never use loved one. Just a little treat for you. You probably are the same way though, I bet. The other piece about caregiving that I think you probably know too is many do not have, it's not a choice. It's like, oh, do I stay home and take care of mom or do I work? Most people feel like they didn't have a choice. The other thing I find frustrating is about 30% of caregivers report that we caregivers don't talk to them about how they're doing or ask them what they need. That we need to make some changes there. And a huge amount said they've never been asked about their own health needs as a family caregiver. So one of the things we know about caregivers is that many of them experience what we call burden. Burden's kind of a diffuse term, but essentially it means feeling stressed out, overwhelmed, unable to keep up with life, and then also in the moment feeling anxious or angry or frustrated. And there are many things about caring for somebody with dementia that contribute to this sense of burden. First of all, it's hard work. And, you know, I have that bullet point that says work. Many caregivers also work outside the home. Probably like you, I have caregivers who care for their family with dementia and then pay somebody to take care of that person with dementia so the caregiver can go out and do their own work. There's a lot of isolation, grief, financial strain. If you think about it, most caregivers are women, and most caregivers as women really experience a lot of financial hardship. The future is very uncertain for many families, and that's why we really try hard to give them a diagnosis. For example, if we give them a diagnosis of frontotemporal dementia, we know that most people with frontotemporal dementia, which I also call FTD, they don't live more than 5 or 6 years. It's a very aggressive type of dementia. But if it's Alzheimer's disease, it could be 20 years, which is very hard on families. So we work very hard to help them manage their burden and find ways to take care of themselves. The behavioral symptoms that come with dementia are a huge contributor to the burden. And there's a couple key points I want to make here. People with dementia and behavioral symptoms, these behavioral symptoms are not, they don't do them on purpose. And I'll talk about that in a moment. The other thing I wanted to point out is, yes, there's a lot of burden in caregiving, but there's also a lot of rewards. And I should probably have another set of bullet points here about the rewards. But for many people, they talk about, you know, a sense of meaning or a sense of giving back. I'm just going to take a quick sip here. Some families, often wives, say things like, you know, before you had the dementia, I didn't have a lot of power in the household. Now I have a lot of power. There was one paper that the woman talked about, you know, I can go shopping now. I can do whatever I want because he just doesn't care. Now that might sound a little harsh, but to that person, that was the benefit. Okay, so what do we mean by behaviors? Because that's really what I want to talk about. That's what I do. Behaviors are tools that help us communicate. So most of the time we use words with our behaviors to develop a clear message. And not all behaviors are bad, right? Think about the last time you were at the airport and you greeted somebody at the gate that you were really anxious to see. Remember that good feeling and what you did. Things like smiling, hugging, laughing. Those are all behaviors that tell us what you're thinking and feeling. Some behaviors, however, cause distress in a family. You know, I like to think about when my son was, you know, young and living with us and he wouldn't clean his room. You know, his behavior was such that he ignored the need to clean his room. And so that could be really frustrating to me. So it caused me frustration. He kind of didn't care. So the trick there was trying to figure out how to deal with my frustration and then understand what's going on. And all of us have challenging behaviors, not just the person with dementia. And so when we work with people in our study, we talk about the behaviors that they're dealing with, but we also talk about how they're experiencing them. Behaviors occur often due to an unmet need that a person with dementia has trouble communicating. So our job then is to identify as best we can what that need is. It could be pain, it could be constipation, it could be hunger, thirst, fatigue, or even just boredom. Now, in the early stages of dementia, whatever type, Alzheimer's, Lewy body, vascular, people can often tell us, what they need. My back is killing me, I need a couple Tylenol. I've always had a bad knee. I need to do something about my knee. Can you get my brace? I'm hungry, I'm thirsty, that kind of thing. But as dementia advances, in most cases, we really lose the ability to communicate efficiently. Because when we have a need, like let's say we have pain, let's say a person with dementia has had chronic knee pain all their lives, but because dementia kills brain cells, it doesn't let us communicate that need. So the first thing we have to do is understand the problem. It's my knee, that's why I'm feeling pain. It's that old knee pain. Well, dementia gets in the way of that. They can't really link the problem to the need. And then actually saying what the problem is. Hey, my knee's flaring up. For many people with dementia, especially in the later stages, it affects what we call fluency, verbal fluency. So they can't really talk to us about what's going on with them. Instead, they may use repetitive monosyllabic statements like or they may withdraw, or they may hit. It's difficult to know the right words, saying the right words, and then communicating appropriately. Again, yelling, hitting, pacing, all of those behaviors are often due to some unmet needs. So when we work with the people in our research study, we ask them to think about it. We ask them to use the ABCs, because it's very helpful to name the issue, to name it, to tame it. So first we say, okay, what is that behavior that you want to work on? What is the behavior that really upsets you? Oh, well, she yells at me. Okay, all right, she yells at you. Then we have to figure out what comes before the yelling, and then what comes afterwards. I have another example in the slide set about a person who has their day nights mixed up. So they are awake at night, or they wake up their family at night, and they're doing things like getting dressed and getting ready. The person with dementia wakes up, thinks they have to go to work, starts getting dressed, and wakes up the family. That's kind of a common symptom we see. So we ask the families first to be a detective. So the very first thing they do when they're in our study is, we don't tell them, hey, go home and try X, Y, and Z. We tell them, take a step back, be patient with yourself, give yourself a break, and all you have to do this week is be the detective. When we come back next week, we want to know all the details about that behavior. So let's say it's the husband getting up in the middle of the night, getting ready for work. He has Alzheimer's disease. He's forgotten that he no longer works. He doesn't have the capacity to work. He can't drive. His memory is pretty poor. So we have the wife go back and just watch. Instead of trying to interrupt or get in the way or solve it or get angry, just watch and tell us what's going on. Then, that's what this is. What we're asking them to do is identify the activators. What comes right before the behavior? So in this situation, it might be a little bit tricky because they might both be asleep, but it'd be really interesting if she could somehow figure out what's going on before the behavior occurs. Like, does he get up to use the bathroom to urinate? And then he starts thinking about work. What happens before that? Then we ask them to think about the consequences. Oftentimes, middle of the night, no, you're not going to work. It's not time to go to work. You never work. You haven't worked for 20 years. What are you doing? The stress levels for everybody go up. This is when arguing starts, yelling starts, hitting starts. Many skilled caregivers know that it's pointless to argue, and they'll just try to redirect. but many caregivers need a lot of support in that area. It's not easy. We then tell them, okay, you figured out what the behavior is. You've told us all about that. You have an idea what the activators are. Now we want you to write down a plan. And then we ask them to please try it. So the plan is a brainstorming plan. It's things like, I'm going to put a sign up in the bathroom that says, nighttime, time to go to bed, so that when he gets up to urinate, he'll see the sign and he'll know to go back to bed. Well, that may or may not work. We don't know, but it's a plan. It's a place to start. If it doesn't work, we try something else. We do other things too. So let me see if I have that example here. Oh, I have father. Let's say it's a spouse because that's a little easier. He's what the wife tells us is he sleeps well during the first part of the night, but then he wakes up in the middle of the night. Sometimes he naps during the day, and he's physically pretty healthy. So when he does wake up, he has no problem getting up and walking around. So again, what we want to know the details about the behavior. What time does he wake up? Really, what time? Is it midnight? Is it 2? Is it 5? Who else is in the home? What does he say? What does he do? What medications do he take? Just the whole picture here. And then we ask, what else is going on? Is the TV on? Are there other noises? You need to use the bathroom? Is he drinking alcohol or caffeine at dinner time? Does he get outside during the day? All those things. And then we talk about the consequences. How are you doing? Are you able to find some time to sleep? Are you getting really frustrated? Is he getting frustrated? It's hard on the family, right? And then we ask them to make a plan. So in this case, the wife might say something like, I'm not going to explain that he's retired. I'm just going to redirect. And we give them this sentence to use: listen with respect, comfort, and redirect. And then we talk about, she says, well, maybe if I get him out in the morning to exercise, that might help him sleep longer. We're like, yeah, that's a good idea. And then we give them tips about how to modify the room if he wakes up. So oftentimes making the room really cold, smoothing out the sheets, putting on a story, some soothing conversation. When a room is really cold, all you want to do is snuggle back down into the bed. And so that often is really helpful. Okay, so again, here's our study. You're welcome to give us a call, or there's the QR code, and then our email is www.Tele-STELLA.org. If you or you know somebody who might be interested in the study, they're welcome to give us a call. The QR code sends you to our screening survey. So you're welcome to use that. And then, I'm sorry, on the first slide, I have the phone number, but I'll give that to you again. It's 503-701-8566. So a couple of important things. It's really important to us that we have people from all across the nation in this study. We don't want just people in Portland, and frankly, we want really rural families. So if you live in a rural area, we'd love to hear from you. Everything we do is by telehealth, computer, texting, that kind of thing. And we loan computers and hotspots to people who need it. Okay. We also do other research at OHSU, and this is our main line for research, 494-7647. So if you're interested or curious about other research, maybe you'd like to take a survey every couple of months and tell us how you're doing. Or maybe you're interested in our technology, or maybe you want to be on the next drug study. Feel free to give us a call. Again, here are the types we do. We have clinical trials, we have online surveys, we have longitudinal studies where somebody comes in and then we see them every year for the rest of their lives. We have 3 caregiver studies going on right now, actually 4. We have mine, and then my colleague, Raina Croft, is doing a study with African-American community members. It's a walking study. And that study is called the SHARP study. So if you're interested in that, you can call this number again, the 494-7647, and ask about the SHARP study. There it is again. Boy, I'm good at giving you phone numbers, huh? And then there it is again. There's our phone number up there. So that's all I have to say. I do have other things we can chat about if you want, things like prevention or other medications, but I think I'll stop here and take your questions because that's the fun part about what we do.
Thank you, Allison. That was really informative. I learned a lot.
Oh, good.
Yeah. So can you describe your study about, because we're a rural area.
Yeah.
We have a lot of folks who are caring for their family members. I will not say loved one anymore. Thank you for that. I mean, so many folks. I can think of several families that I've worked with who are not well resourced, who are, you know, it takes a while to drive to a doctor's appointment. Getting their family member in a car is sometimes difficult.
Oh, it's so hard. I mean, that's why we did the study. I mean, we started this work in 2016 for those exact reasons. First of all, it's kind of not fair that if you're a caregiver and the only place you can get help is in Portland, right? But more importantly, it's really hard to get somebody with dementia from place A to place B, especially if it's in the moderate to severe stages. So we do those, the ABCs I was talking about, we do that with the people in the study to see if it works. I mean, I sit here and I talk about, well, it's really helpful, you know, it can reduce burden, but there isn't a lot of science behind it. So we ask people to join us. They meet with us for 8 weeks. The first 4 weeks are one-to-one with our nurses. They sit down, they talk about the things that are bothering them. They do that for 4 weeks, one-to-one. And then the next 4 weeks is they meet in a small group. So it may be 2 or 3 or 4 other caregivers in a similar situation. And again, they work through things like that. They work through the ABCs, but then they put it in context. Like, for example, 1 week we talk about pleasant events. It's important to get out. It's important to have fun together. Well, how can we use the ABCs to make life more fun for you? That kind of thing. After those 8 weeks, we do measure a person's burden, but then we invite the families back into anywhere between 2 and 6 months to join a larger group. It's the same intervention, but the focus of the group is really getting people together. We want our participants to call each other, text each other, support each other. So the second weeks will have, 8 to 10 people working through the same thing. We call it a booster that gives them a chance to connect with other people on a really deep level. Again, everything's done remotely. We have a technology person. Her name is Steph, and she helps us with all our technology. So if a person has their own computer at home, but they're having trouble connecting, Steph will get them all set up. If they don't have a computer, Steph will get them a computer and a hotspot. And I think it's a great study. It's an hour a week. It's work. I mean, it's work for caregivers who are already pretty busy. We're hoping that it reduces the strain in their life, but because we recognize that as work, everybody that finishes the program gets $100. So we really try to meet them where they are. And to your point, we recognized early on this should be available to anybody that has a computer, and if they don't, we'll give them one.
So is equipment the biggest barrier that you found?
No, it's not. I think about 90% of our participants have their own computer, or they meet with us on their phone. The biggest barrier is caregivers are too busy. So that's the first reason that people either don't join or drop out, which I have a great deal of respect for. The other reason that people don't join or drop out is because their family member with dementia has died. So we take people even in the late stages of dementia, because we know that even in the late stages of dementia, there are behaviors that cause strain in the family. So we welcome them, and we realize, it's possible that your family member might die while they're with us, but no reason not to work on it now. So.
And I remember when we first spoke back in the fall,
a long time ago,
we were chatting about, even if the family member doesn't live with the caregiver, you also provide support. Can you talk about that?
Yeah, I love that. Thank you. You're really helpful. We know that people, whether your parent, your spouse, your sister, whatever, even if they don't live with you, say they live in a memory facility, your stress level is still probably pretty high. And so you don't have to live together. And we also realize that it's hard to count how many hours of care you give per week. In many studies, you have to give 8 hours of care. And it's like, do I do 8 or do I do 7?
Right.
We just say 4 hours. Most people get in. That's usually not a barrier.
Okay. Looks like we have some questions.
Oh, good.
Oh, Linda has a good comment. She says, I found it was more helpful to substitute inability to process information than memory.
Yeah.
Situational memory. That's interesting.
I think Linda points out a good point in that it's an art to communication. I notice, like, when I see people in clinic, if I say, oh, you're here because you have Alzheimer's disease. Well, first of all, in many people, the symptom of Alzheimer's disease is impairment in memory. So they probably have forgotten that they've been given that diagnosis. So if I walk in and say, oh, you have Alzheimer's disease, it could be very distressing. So I spend a lot of time kind of figuring out with the family, like, what are they calling it? What words are they using? Are they talking about it? Some families are like, oh, yeah, we talk about it all the time. Some families pull me aside and say, please don't say anything. Why? I mean, I don't want to distress the family any more than they already are. So good point, Linda.
Yeah. Oh, Robert.
Goodness gracious.
Yeah, I'm an 83-year-old male caring 24/7 for my wife who has stage 4 cancer for the last 4 years. I am experiencing many of the symptoms on the slides. Should I reach out for help? And if I don't, I worry who will take over care for my wife. I can no longer retain short-term memory. It's terrible, and I'm a sick puppy.
Oh, Robert, my goodness. Yes, give us a call. We'd be happy to talk with you. We do have what we call screening criteria, so we'll walk you through it. Whether or not you can join us, I bet you, Joelle, have good ideas, but definitely need to connect with services to support you. You may live in a really rural area, but there's still, social workers and lots of services available to you. I'm so glad that you are thinking about this because it will help you and your family down the road. And do give us a call. We'd be happy to hear from you.
The planning, you spoke to planning. And it seems like with the ABCs, it's more situational planning, moving from B to or A to C.
Yeah. What we want is we want the ABCs to be a scaffold for any problem. And so we teach people, here is your plan. So for example, in Robert's case, the behavior may not be about his family member. The behavior may be, I'm stressed, I'm tired, I'm worried. Okay, that's the behavior. Now what's causing it? I don't know what the future holds. I don't know who's going to take care of my wife. There's so many unknowns. I don't know what I'm going to do. The consequences are I'm really stressed. So let's make a plan. And you're going to write down, I'm going to call my primary care provider and ask for a referral to social work. Or I'm going to call Joelle and see if she has any ideas to help me. Or I'm going to call my son and say, it's time to come up and make a visit. So Robert could use that scaffold of the ABCs for his needs as well as his wife's.
Oh.
And so when they walk away from our program, they have the ABCs for whatever it is that is getting them down.
Yes.
Yeah, I hear you, Robert. He wants to sleep a lot. Yeah, that's tough. I mean, you've got a lot going on there.
Yeah. So Maureen, who is our Veterans Services Coordinator, Veterans Outreach Coordinator. I love, she comes in with that veterans perspective, which is so important.
It's so important. Yeah, it really is.
Yeah, she says, have you worked with many veterans? Do you have any unique recommendations for supporting veterans?
Yeah, that's a great question. I do. I work with a fair amount of veterans, which always surprises me because the Veterans Administration has a lot of resources for families with dementia. And in fact, some of the studies that have been done in families, some of the early, even current studies for caregiving are done at the VA. So if I meet a family who has a vet, I make sure that they connect with the VA. And not only do they provide great dementia-related services, they provide great caregiver support. And they have great programming for caregivers. Now, in our exact study, I can't tell you who's a veteran and who isn't off the top of my head, but we do collect that data. So when we're done with this study in 2026, we'll be able to go back and say, yes, X% were veterans. And we may even be able, if we have enough of them in the study, we may be able to say things like, people who are veterans did a better job finding support in their community, or people that were veterans improved more when they were in this study. So we love veterans. We'd love to have more veterans. The other thing I wanted to pass on to Maureen is I do support groups too, and I do get a lot of feedback that it's hard to get into the system. So I guess that's something that Maureen and I should have a different conversation about. But I just tell them, keep going back, because when you're in, they take care of you.
Yeah, she's skilled at that.
I'm so glad. So glad.
So, Allison, something that we have started at Partners in Care is called a caregiver cafe, and we're starting it from, we're building it as we go.
Great.
It's April 5th from 10 to 11. And the idea is just to provide a social outlet to avoid isolation and burnout, and also to provide resources, kind of have a theme every month.
Yes.
Yeah. Is there anything in particular that caregivers would benefit from at a setting like that?
Yeah, we have caregiver cafes here in Portland, and frankly, I love them. I mean, I go just because it's fun, but they're a great way for people to gather and not have to deal with the stigma of society. And usually our caregiver cafes have some kind of music. So at the last caregiver cafe, we were all doing the hokey pokey. Do you guys all know what the hokey pokey is? So everybody know what the hokey pokey is? I'm
glad to teach you if you don't know.
Yeah, please. And it was so much fun. And so we usually have music. We have, before COVID, we used to have a buffet. Now we just hand out like granola bars. But it's funded by the county, but also by the Layton Center. We give some money. Other organizations give money to support the event. And so because of that, they give us a couple minutes to talk about what we do. So if somebody like Robert came to the cafe, he may meet like a social worker or a VA representative, or heck, a speech therapist, somebody to make his life a little bit easier. So it's a great way for caregivers to meet other people. Yes. Good for you. I'm excited about that.
Oh, thank you.
Let me know how it goes.
Thank you. Well, I have a million more questions. I just want to make sure. Okay, Linda, yes, when you're dealing with dementia, you can't get away in the later stages. That is true.
That's exactly why we do the telehealth intervention. And oftentimes when people come to our study the first week, many families say things like, he's too clingy, I'm not going to be able to be in a quiet room for an hour with you. So the first thing we work on is, okay, what are some strategies we can use? So he can be in another room and you can work with us for an hour or even 45 minutes. Because that's an issue for sure. And some people just can't. And we respect that.
Sure. And, we thought about that with the cafe having, having an event for caregivers who, it's known that it's hard to get away, but also how important it is to get away.
Yeah, it is. So the cafe is specifically for caregivers. It's not for the caregiver and their care recipient.
Right.
Oh, okay. Sorry, I misunderstood. So in Multnomah County, we do memory cafes is what we call them. And it's for the person with dementia and the caregiver. And the point is to give resources to the caregiver, but also to break up their day and give them a chance to get out, give the person with dementia a chance to get out. But yeah, I hear what you're saying. It's also important to have it just for caregivers. It's hard to know.
Well, it'll evolve, I'm sure.
Yes, it will. And another thing I want to pass on, I hope this isn't your experience, but it was an important one. Sometimes at the cafes, only 3 or 4 people show up and it's fine. It's worth the effort.
for sure. You mentioned Bruce Willis has FTD.
Yeah, he does. He has,
Oh,
I believe, I'd have to look it up. So, I talked from earlier on about how dementia is an umbrella term with different types. Well, it gets even worse. FTD is an umbrella term for different types. And I think Bruce has, I believe it's primary progressive aphasia. So it's a type of FTD that severely impairs our ability to communicate. So even though our memories may be okay, we can't get the words out. We can't understand the words. Communication is very hard. So a person in that situation, it's critical that they have a good speech and language pathologist on their team. So there are speech and language pathologists who specifically deal with communication, not just swallowing and eating, but actually communicating.
interesting. Okay. Huh. Yeah.
Yeah.
Can you?
And Northwestern University has some big studies on that type of diagnosis. So hopefully he's getting linked in.
I'm curious. It's kind of known, Robin Williams also had, was it Lewy body
Lewy
dementia?
body. Mm-hmm. Yeah.
You described wonderfully the mechanism of Alzheimer's disease with the plaque, and that makes sense to me. What is Lewy body? What is that? Is that lesions? What is that?
Well, that's one way to explain it. It's a little bit difficult to explain because it is complicated. It is actually what they call Lewy bodies. So they are little cells that infiltrate a part of the brain that cause this damage. And it has to do with the tau theory. They think it's more of a tau-like. So if Alzheimer's is affected by amyloid proteins and tau tangles, Lewy body often is more tau related, and it's actually Lewy cells in the brain. So when we do autopsies at the end of after death, we do see what they call Lewy bodies that infiltrate the brain and kill the cells that affect not only vision but movement and memory. It's a tough one. And because of that, I often do refer people with Lewy body to the Lewy Body Dementia Association. Very strong association, great support group. So.
Okay. Yeah, that's interesting. We have a very strong Alzheimer's Association here in Central Oregon.
Yes, great. I'm so glad.
Yes, very, very strong presence here. But I have not met anyone from the Lewy body. So
great. I can connect you.
Okay.
Yeah, I'll send you a couple of names. I can't think of off the top of my head, but we have one person here in the region that does a telehealth support group for Lewy body. And then at our center, I do the telehealth support group for people with FTD. So,
you did mention mixed dementia, and this is the first time I've ever heard of multiple dementia diagnoses.
Yeah, it's confusing. It's the problem with dementia is that it's hard to diagnose. And then what we do at our center is many people volunteer to donate their brains after death. So we actually look at the brains, and about 25% of the time, we didn't get the diagnosis right. And many times, most of the time, there's several processes going on. So for example, if a person has mixed dementia, they are frankly at increased risk for Alzheimer's disease. And every once in a while we meet somebody with like pure Alzheimer's, but often it's a combination of factors. The treatments are usually the same. The only time they vary is if a person has frontotemporal dementia. So, yeah. So.
An anonymous question. Are there tips for preventing dementia that you could share? You did kind of touch on this.
I love it. A plant. Okay, yes. Hang on. I got it. Got it for you. Okay, let me get there. Come on, you. Okay. So can I prevent dementia? I do a talk every quarter with the Oregon Care Partners. I know you know of them. They provide free education for anybody that cares for somebody in Oregon. And my talk it's called Dementia Q&A. So if any of you are interested, it's on Oregon Care Partners. I think the next one is maybe in May, I'm not sure. Anyway, and this is often a common question, how can I prevent it? Well, we can't guarantee you that it can prevent it. I think that's the thing that's so maddening about it. You know, you have somebody who's like a scientist and they exercise every day and their cholesterol is perfect and their blood pressure is perfect and they still get Alzheimer's. But there are things that we can do to help us out. So get your hearing checked. Hearing loss increases the risk of developing dementia. If you have hearing loss, get hearing aids. We still don't know for sure if using hearing aids reduces your risk, but intuitively it makes sense, right? Plus, if you can't hear something, you can't remember it. So definitely get your hearing checked. Even mild hearing loss increases the risk. Do control your blood pressure. We do want blood pressures around the top number to be around 120. For some people, that's not possible, and that's okay. But as long as you have a good conversation with your primary care provider to stay on top of that. Controlling your cholesterol is really important. Exercise is so important. That should be at the top of the list. And by exercise, I mean 4 to 5 times a week for 45 minutes, break a sweat. It's good for the heart, right? It's also really good for the brain. It helps keep the blood flowing. It helps clear away, well, you know, it helps clear the brain, right? All of us feel better after we exercise. If you're not used to exercising, just do a little bit every day to get yourself in the habit and then build on it to break a sweat. We want you to sweat. Spend time with friends. It's really important to be social, to be out there talking to people, going to the cafe, spending time with others. That's critical. A healthy diet is important, but don't obsess over it. Everything we want you to do, we want you to feel good about it. And I've met many families who like eliminate all sugar. It's like, well, that's no way to live. But a healthy diet, you know, olive oil, fish, nuts, add those in. Alcohol in moderation. Women, unfortunately, we only get 7 glasses of wine per week, and that's not 7 glasses in one night. That's like across the week. So we have to control that. And then for men, it's a little bit higher. I think it's like 9, but keep the alcohol maybe about 1 glass a night, if even that. And then if you're stressed out, if you're a caregiver, get help, get support, meet other people. And then lastly, if you're having trouble with sleep, get an evaluation. Sleep is really important. Oh, and I have one more. If we have 1 more minute, these are medications to avoid. Sleep medications can contribute to memory trouble. And if they're used a lot over many years, they can contribute to impairment. I'm fine. I love Advil. I love Motrin. It's the PM and the SOM that you want to watch out for. Those, I feel like these medications should be labeled as dangerous because I've seen not only do they cause us to feel foggy in the morning, they can contribute to falls because they're what we call anticholinergics, and that affects our neurotransmitters. So you have the slide set, so I'll leave that with you.
Good to know. One last question, and then Linda wanted to know about carrying the gene.
Yeah. Yeah, there's a rare type of Alzheimer's disease which is genetically predictive. Other types of dementia, if your parents had it, you don't automatically mean you'll get it. So there may be a little bit of genetic crossover, but it's not automatic. Let me put it that way. In fact, we do discourage people from doing 23andMe because we still don't know enough. So if you have what they call the A4 allele, yeah, it can increase your risk for Alzheimer's, but it doesn't automatically mean you'll get it. So we ask people to be really careful about that. Live a good life.
Right.
Don't borrow trouble from the future.
Oh my gosh, I need that written down somewhere.
We all do.
Don't borrow trouble from the future. I love that.
Yeah.
Well, Allison, thank you so much.
Oh,
for
pleasure. Yeah, I
spending
love
time
this.
with
I
us.
love talking with people. You have my email. Feel free to send me
Yes.
questions. And I hope you can all get outside and appreciate the sunshine today.
Yeah, me too. So I'll be sending up a follow-up email next week.
Oh, yeah.
Please take a minute, fill out that survey to everyone who joined us today. And look out for, I'll send information about the Caregiver Cafe, and also our next Community Ed is April 21st. So we'll see you all then.
And when you fill out the surveys, I do read those and take them very seriously. So thank you in advance for doing that.
Yeah. All right. Take care. Happy St.
Bye,
Patrick's
everybody.
Day.
You too. Bye-bye.